Hello and welcome to Medis Academy. This is Dr. Godfrey Mombi. Today we are discussing appendicitis. First things first, what's the appendix? The appendix is a worm-like structure that you find at the junction of the ileum and the cecum. This appendix can sometimes get inflamed. And when it gets inflamed, that's what we call appendicitis. By definition, when we say appendicitis, we're actually referring to acute appendicitis because it's the acute version that brings about the clinical characteristics that are alarming and the ones that will require emergency attention. So by definition, we define appendicitis, that is acute appendicitis, as inflammation of the vermiform appendix. Again, the word vermiform in this case meaning that it is shaped like a worm. It's usually due to luminal obstruction, and it leads to ischemia, bacterial overgrowth, and potentially perforation. As you're going to see later on, perforation is one of the worst outcomes of appendicitis. So what causes appendicitis? When you look at its etiology, you'll find that one of the most common causes is luminal obstruction, meaning that the internal diameter of the appendix, remember what I said, the appendix is part of the large intestines. So it bears the same characteristics. It's got a lumen. And sometimes that lumen, that internal diameter, can get obstructed. But what are some of the things that can cause luminal obstructions? One of the most common causes are what we call fecaliths. Fecaliths are hardened feces. So picture stools as they descend down the alimentary canal, they progressively become harder. As more water is absorbed, they become harder. As they harden, over time, calcification may start happening. That is to say, calcium starts getting deposited. And when calcium gets deposited, they even become harder than they were before. So when this happens, we call these fecaliths. Some texts will call them appendicoliths. It's just the same idea. What these will do is, because they are not moving, they can obstruct the lumen of the appendix. So that is one of the most important causes, appendicoliths or fecaliths. Then we can have lymphoid hyperplasia. So when you look at the histology of the appendix, you find that the appendix contains a lot of lymphoid tissue. And what happens, especially in children and adolescents, is that when there's a viral infection, the likes of adenovirus, measles, mononucleosis, this can trigger the lymphoid tissue to become hyperplastic. And as it becomes hyperplastic, it starts growing inside the lumen. Sometimes this can cause luminal obstruction. Then you can have foreign bodies. So imagine this person has, whether intentionally or accidentally, taken in a foreign body, something like a seed, small pins, or other swallowed items. These items can cause obstructions in the appendix. And when they do that, then we can have appendicitis. Then you can have neoplasms, the likes of carcinoid tumor and other types of tumors. As the tumor grows inside the lumen of the appendix, it starts blocking the contents of the appendix. They can no longer move freely. As a result, that will cause luminal obstruction, and that will lead to a series of events that we're going to talk about later. You can also have parasitic infections. Imagine a parasite has invaded the GI tract, and these parasites have, in particular, invaded the appendix. If there are a lot in number, the likes of Enterobius vermicularis, Ascaris lumbricoids, even schistosoma, these can cause obstructions. And once you have luminal obstruction, then the risk of having appendicitis is quite high. So what's the epidemiology of appendicitis? The overall lifetime risk is about 7%, and appendicitis is the most common cause of acute abdomen that requires surgery. Peak incidence is in the second and third decades of life. When it comes to risk factors, the age group, as we have said, the second and third decades of life, so you're talking about 10 to 30 years. There's a slightly higher incidence in males, and when it comes to diet, it's been found that a low-fiber diet, because it increases the chances of getting constipation, and when you have constipation, increased water absorption, the chances of developing fecaliths are very high. And if you remember, fecaliths will cause obstruction of the appendiceal lumen, which will cause appendicitis. We talked about lymphoid hyperplasia. So a recent viral GI or respiratory infections, which can trigger that lymphoid hyperplasia, that becomes another risk factor. Then there's family history of appendicitis and also poor sanitation. How is poor sanitation coming into the picture? With poor sanitation, the chances of getting parasitic infections is high, and those parasitic infections can then obstruct the lumen of the appendix. So how do we classify appendicitis? We can classify it based on different factors. If we classify it based on time frame, then we can have acute appendicitis. This is the most common. With this one, you have rapid onset of inflammation of the appendix. Then we can have chronic appendicitis. This one is rare, it's recurrent. The levels of inflammation are milder than acute appendicitis, and as the name suggests, it's chronic, it's not rapid. Then we can have recurrent appendicitis. This is where we have episodes of self-limited right lower quadrant pain that is due to partial obstruction. So there is some form of obstruction, but it's not complete, okay? The lumen is obstructed, but not all of it. There is some space that has remained for contents of the appendix to pass. As a result, you may have some level of inflammation, but it's not as much as you would find in acute appendicitis. We can also classify it based on severity, okay? So in this case, we can have simple or uncomplicated appendicitis. What's happening here is that we have an inflamed appendix, but it's intact, okay? It's inflamed, but intact. With complicated appendicitis, it now means there are complications. So with this one, you can have gangrenous appendicitis. What's happening here is that there's neuronecrosis. There's necrosis of the wall of the appendix. This one happens especially in the mucosa and the muscularis. And when there's gangrenous appendicitis, there's that neuronecrosis, blood supply is compromised. When we have compromised blood supply, ischemia is just around the corner. The wall becomes greenish, it's a bit black, greenish black. It's also friable. You can also have perforated appendicitis. This one happens when there's full thickness necrosis that leads to rupture of the wall. When the wall ruptures, it means free pus or fecal matter or whatever the content of the appendix may be can now flow into the peritoneal cavity. When that happens, we can have peritoneal irritation that is coming as a result of the content of the GI finding itself in the peritoneum. Remember also that GI content contains a lot of bacteria. Those bacteria can wreak havoc once they are in the peritoneal cavity. You can also have an appendicular abscess. What's happening here is that we have a localized collection of pus that results from a contained perforation. So a perforation has happened and pus has collected, but it's been localized, okay? You can also have an appendicular mass, what is also called a phlegmon. This one is an inflammatory mass that is formed by the appendix, the surrounding bowel, and the omentum. Then we can have special forms of classification. These ones are based on the location of the appendix. So the appendix is not always just in one position. It can occupy different positions in different people. So depending on where it is located, if appendicitis develops, we can call it by that name. So we can have post-ileal appendicitis. This one is happening when the appendix is post-ileal. We can also have pre-ileal appendicitis when the appendix is pre-ileal. Sub-ileal appendicitis, it's now below the ileum. Pelvic appendicitis, it's projecting towards the pelvis. We can have subcecal appendicitis, it's now below the cecum. We can have paracecal appendicitis. We can also have retrocecal appendicitis. We also have other special forms of classifying appendicitis. You can have subhepatic appendicitis. As the name suggests, This one happens when the appendix is just below the liver. This one is seen when the cecum fails to descend during development, and as a result, the appendix appears just below the liver. This one can give you right upper quadrant pain, which can confuse you because you may start thinking the origin of the pain is either from the biliary tree or from the liver itself. We can have left-sided appendicitis. This one occurs in situs inversus or malrotation. So in situs inversus, what we have is that the contents of the GI that are normally found on the right find themselves on the left. So there's that reversal. And since the appendix is on the right, under normal circumstances, in situs inversus, you find it on the left. You can also have stump appendicitis. With stump appendicitis, what's happening is that this person had appendicitis before, and it was treated by removing the appendix. An appendectomy was done. But after that appendectomy was performed, the residual appendiceal tissue, okay, so after cutting out the appendix, the tissue that remained, the residual appendiceal tissue, became inflamed. Okay, so this one happens when there's inflammation of the residual appendiceal tissue after an appendectomy. You can also have appendiceal endometriosis. Okay, you know that endometriosis happens when contents of the endometrium find themselves outside the uterus. Okay, so they can be anywhere in the GI. If they find themselves in the appendix, then we can have appendiceal endometriosis. This one is rare, and it involves endometrial tissue finding itself in the appendix. You can have tuberculous appendicitis. As the name suggests, this one is caused by Mycobacterium tuberculosis. So in this case, remember that TB can infect almost any organ of the body, okay? And the GI organs are not spared. So if the appendix is the one that's been infected, then you can have tuberculous appendicitis. Let's now talk about clinical manifestations, okay? So with appendicitis, you have certain classic symptoms of appendicitis, those ones which you have to know, they are non-negotiable, okay? One of them is periumbilical pain, okay? This periumbilical pain then migrates to the right lower quadrant. And this migration of pain from the periumbilical region to the right lower quadrant is a key feature of appendicitis. Then there's anorexia, there's nausea, which may or may not be accompanied by vomiting. And if there's vomiting, this vomiting happens after the pain starts. Patient may have a low-grade fever. There may be constipation. Sometimes there may be diarrhea. Apart from that, there are other physical signs. One of them is rebound tenderness. With rebound tenderness, what's happening is that it hurts more after you stop pressing. Okay, so when you press, then after letting go, if it hurts more after that, then that's rebound tenderness. There'll also be guarding, rigidity, and this will be more pronounced when there's perforation. Another important feature is that there will be tenderness at McBurney's point. Okay, now McBurney's point is something you have to be familiar with if you want to have a deep understanding of appendicitis. It's located, the landmarks that you use are the anterior superior iliac spine and the umbilicus. And McBurney's point is that point that is 1/3 away from the anterior superior iliac spine and 2/3 from the umbilicus. Okay, the point where those two dimensions meet, 1/3 from the anterior superior iliac spine and 2/3 from the umbilicus, that point is McBurney's point. So McBurney's point tenderness is one of the most important features. You also have what is called Rovsing's sign. Rovsing's sign is positive when after palpating the left lower quadrant, there is pain in the right lower quadrant, okay? So in this case, you have right lower quadrant pain that comes with left lower quadrant palpation. This is very interesting because while the patient is lying down, facing up, you are palpating the left lower quadrant. the appendix is on the right. So you are palpating the left lower quadrant. But as you do that, the patient experiences pain in the right lower quadrant, okay? What's happening here? What's happening is as you press the left lower quadrant, you push abdominal content away from the site where you're pressing. And those organs of the abdomen, okay, in this case, we're talking about the large intestines and or whatever else may be there, as they get pushed away from the left lower quadrant, they'll move towards the right. Now, remember that this appendix is inflamed. So when they get in contact, when they come in contact with the inflamed appendix on the right, there will be pain in the right lower quadrant. So that is called Rolfing sign. You are palpating the left lower quadrant, but the patient experiences pain in the right lower quadrant. Don't forget that. This is called Rolfing sign. Another important sign is called psoas sign. This one is positive when there's pain on hip extension, okay? And it's more common in retrocecal appendicitis. What's happening here is that the patient is lying on the left lateral side, and the clinician in this case extends the hip, okay? As they extend the hip, let's go back to the anatomy. Extending the hip in this case is going to stretch the psoas muscle, okay? That's why it's even called the psoas sign, because it involves the psoas muscle. The psoas muscle is close to the appendix, okay? And as that psoas muscle stretches, it comes into contact with the inflamed appendix, and that will cause the pain that we're looking for, which is called psoas sign. So this sign is positive when there's pain on hip extension. The other sign is what is called the obturator sign, okay? This one happens when there's pain on internal rotation of the flexed hip, okay? So in this case, the patient is lying supine and the hip is flexed, then it is rotated internally, okay? That internal rotation of the flexed hip is going to stretch the obturator internus muscle. And the obturator internus muscle, as it stretches, it will come in contact with the appendix, especially if the patient has a pelvic appendix, the one that points towards the appendix. When that happens, the patient is going to experience pain, and that is when we say the obturator sign is positive. So in simple terms, obturator sign is when there is pain on internal rotation of flexed hip. So what's the pathophysiology of appendicitis? Appendicitis happens when there's, as we mentioned earlier, when there's obstruction of the lumen, okay? Now what happens here? When the lumen is obstructed, then obviously nothing is moving, okay? So what will happen then is that we'll have a lot of mucus secretion. With increased mucus secretion and nothing moving out, there is increased intraluminal pressure. When that pressure starts building up, we can have venous congestion, and with venous congestion, we can have ischemia. So in simple terms, there's an obstruction, things start building up, pressure increases. As a result, the veins are not able to drain blood from the appendix. With that, we have ischemia, and when ischemia sets in, we can have death of tissue, that is necrosis, but also because nothing is moving, we have stasis inside the appendix. Bacterial overgrowth is going to take place, especially here we're dealing with the likes of E. coli, bacteroids, and when you put everything together, there's ischemia, there's bacterial overgrowth, inflammation is all over the place. So there will be transmural inflammation, which can cause perforation because the wall of the appendix has been weakened. When that perforation happens, then whatever was in the appendix will find its way into the peritoneum. Now, the peritoneum is quite sensitive. There will be peritoneal irritation. We can have peritonitis. We can have abscesses. Those bacteria that were found inside the lumen of the appendix will now start reproducing inside the peritoneum, that is not a good picture. So that is the pathophysiology of appendicitis. Okay, let's now talk about investigations. Okay, when you do your full blood count, you're going to find that the white cell count is elevated. And to be specific, this is going to be neutrophilic leukocytosis. Why is it like that? You have to remember that in acute bacterial infections, neutrophils are usually the first cellular responders. And that's the reason why you'll find neutrophilic leukocytosis in this case. When you check your CRP levels, CRP will also be elevated. Remember that CRP is a non-specific inflammatory marker. It tells you that there's an inflammation, an inflammatory process going on somewhere, but it won't tell you exactly what type of inflammation is going on. There'll also be an increase or a rise in procalcitonin. Now, procalcitonin is a peptide precursor of the hormone calcitonin. It's produced mainly by the thyroid C cells, that is under normal circumstances. But it gets elevated when there's a bacterial infection, especially if that infection is systemic or severe. This infection can stimulate procalcitonin release through a number of inflammatory mediators. As a result, it also gets elevated, and it's one of those things that we'll use as markers of inflammation. When you do urinalysis, you may find that it shows mild white blood cells. This may be due to irritation near the ureters. Then, if you are dealing with female patients, you also have to do beta HCG. Remember that beta HCG is a marker of pregnancy, and we are basically testing if this woman is pregnant. What's the reason? The reason for this is that if this woman has an ectopic pregnancy on the right, it's going to mimic appendicitis. Actually, it becomes very difficult to distinguish between an ectopic pregnancy on the right and appendicitis. As a result, in order not to miss this ectopic or this potential ectopic pregnancy, you have to do this beta HCG. You check the beta HCG levels. If the levels are normal, then you are potentially dealing with a real appendicitis. If not, if you find the levels are elevated, then this might just be an ectopic pregnancy. This is a very important point because you cannot afford to miss an ectopic pregnancy. You know that ectopic pregnancies can be life-threatening. Patient may be bleeding and they may go into shock and you may lose the patient. So it's always important whenever you're dealing with female patients, especially if these patients are in the fetal age group, if they are of childbearing age, you have to do beta HCG levels whenever you suspect appendicitis, just to be sure. A lot of times, ectopic pregnancies mimic appendicitis, and clinically speaking, especially in the acuteness of the emergency ward, you barely have enough time to exclude or to rule out an ectopic pregnancy clinically. So you have to do beta HCG levels. Then apart from that, you can also do serum electrolytes and creatinine. This is just to assess for surgical fitness. Remember that these patients will most likely have to undergo a surgical procedure where the appendix is removed. So you have to assess for surgical fitness. Then blood cultures. This is important in order to know the specific strains of bacteria that you're dealing with. When we get to imaging, we have ultrasound as the first line investigation, especially in children and pregnant women. This will review a non-compressible tubular structure that's greater than 6 millimeters in the right lower quadrant. There may be free fluid or an abscess, and specifically, it's going to review a positive target sign. So this appears as a series of concentric rings on ultrasound images with a fluid-filled center surrounded by echogenic, that is bright, and hypoechoic, that is dark layers. These will resemble a target or a bullseye. As you can see in the picture on the right, there's that target, and then you have concentric rings around it. The image on the right is an actual ultrasound image that is showing that target sign. You can see the center and then those concentric rings around it. This is another image that is showing the same thing. So this is what we mean by target sign. On CT, this one is done with contrast, so CT abdomen with contrast. This is the gold standard in adults, and it will show an enlarged appendix that is usually greater than 6 millimeters. There will be wall thickening, there will be periappendiceal fat stranding, and even appendicoliths can be seen. MRIs will be useful in pregnancy if ultrasound is inconclusive. This is a CT image showing the enlarged appendix. You can see that there's fat stranding, and fat stranding in this case simply refers to the appearance of fat around the appendix that is on imaging, especially when you're doing CT scans. And this fat shows increased density, and you can see it as shown in the picture here. This is what appendicolith will look like. Remember, an appendicolith is just a mass of hardened and sometimes calcified feces. Generally, if that happens anywhere in the GI, we call that fecaliths. But when we use the word appendicolith, we mean it's specifically found in the appendix. So you can see where those yellow arrows are pointing. Those are appendicoliths. So when we put everything together, we will now have our diagnostic criteria. This will include your clinical findings. So a clinical diagnosis is primary. Then it will also include imaging findings. What did you find on your imaging? And something we call the Alvarado score. So the Alvarado score is a score that we use to measure the likelihood of there being appendicitis. It is out of 10 and it contains different components. So as you can see on the screen, we have features that we'll consider on the left and what score is assigned to them. The first one is migration of pain. Remember the type of pain we talked about earlier, periumbilical pain that migrates to the right lower quadrant. If this is present, it is assigned a score of 1. Then we have anorexia. If anorexia is present, we have a score of 1. Then we have nausea. If it's present, we have a score of 1. Then we have tenderness in the right lower quadrant. If this one is present, we have a score of 2. Then we have rebound tenderness, which if it's present, we assign a score of 1. Then we have elevated temperature. If it's present, we have a score of 1. Then we have leukocytosis. If this one is present, we have a score of 2. The last one is a shift of white blood cell count to the left. If this one is present, we have a score of 1. Now, what does this mean? When we say there's a shift of white blood cell count to the left, it means we have premature white blood cells in circulation. And specifically, this happens with neutrophils. So we have premature neutrophils in circulation. The idea here is that the bone marrow is doing all it can to help out with this acute infection. So it's recruiting as many mature red blood cells that are available as possible. But sometimes, depending on the severity and the acuteness of the infection, sometimes the bone marrow starts bringing on board these premature neutrophils, these premature white blood cells. Sometimes these are called band cells. So if this happens, where we have these premature neutrophils in circulation, we call this a shift to the left. And if this is present, we assign a score of 1. When you add all these numbers together, they give us a total of 10. So how do you use this now to help you understand the likelihood of there being appendicitis? If the score is greater or equal to 7, there's a very high likelihood of there being appendicitis. In this case, you have to consider surgery. If it's between 5 and 6, it may or it may not be appendicitis, so you may have to do more imaging and observe the patient. If it's less than 5, this is unlikely to be appendicitis. So that is how you use the Alvarado score. So how do you manage appendicitis? We're going to divide management into pharmacological and non-pharmacological. Under pharmacological, we'll have IV fluids. This is obvious. Remember that these patients are most likely in shock, so you have to give them fluids. Then you can give IV antibiotics, okay? So in uncomplicated appendicitis, you can give ceftriaxone, metronidazole. Then in complicated cases, you can give broad-spectrum antibiotics such as piperacillin, tazobactam. Don't forget analgesia, so you can give paracetamol and an opioid. Non-pharmacological management will involve surgery. So an appendectomy is the definitive treatment modality. Laparoscopic appendectomies are preferred because they come with faster recovery and less infections. Open appendectomies may be done in complicated cases or in resource-limited settings. Then in selected cases, non-operative management techniques can be employed. So if you are dealing with an uncomplicated appendicitis in a high-risk surgical patient, you may consider non-operative management. In this case, you may only give antibiotics alone and employ close follow-up because the risk of recurrence is quite high. Then sometimes even in complicated appendicitis, non-operative management techniques can be employed. For example, if you're dealing with perforation or an abscess, percutaneous drainage of that abscess, if it's been warded off, can be employed. Then later on, an interval appendectomy after 6 to 8 weeks can be done. The same thing can be done if there's a phlegmon or a mass, that is to say, delayed surgery or interval appendectomy after 6 to 8 weeks. When it comes to complications, perforation is right there on top. Because of that perforation, we may end up with peritonitis, sepsis. We can also have abscess formation. That's another complication. Then appendicular masses can form, also called phlegmons. Then we can have sepsis, which can lead to shock. We can have adhesive small bowel obstructions. Wound infections after surgery are possible. Then we also talked about stump appendicitis. This one is rare, but it's possible. In this case, after appendectomy, the stump, the residual appendiceal tissue, gets inflamed. That is what we call stump appendicitis. This is also another possible complication. Other important points to remember are that children and the elderly have atypical presentations of appendicitis, and they also have high risk of perforation. Remember that in pregnancy, there's a higher risk of misdiagnosis. The imaging technique of choice is ultrasound or MRI. Remember that stump appendicitis is possible. Then, generally, with appendectomies, we strive for a negative appendectomy rate of less than 20%. Negative appendectomy rate means after you have performed that surgery, you've removed the appendix, then you've done your histopathological analysis, then you find that the patient did not actually have appendicitis. That is called negative appendectomy rate. Ideally, it should be less than 20%. That is what we strive for. In order to achieve this, one has to be very good with their diagnosis. Then there's this mnemonic that may help you: pain, P for pain migration, A for anorexia, I for increased temperature, and N for neutrophilia. Then the Alvarado score that we talked about can be remembered by the mnemonic mantras: M for migration, A for anorexia, N for nausea, T for tenderness, R for rebound tenderness, E for elevated temperature, L for leukocytosis, and S for that shift to the left. Thank you very much for watching. Remember to like, share, and subscribe, and wishing you all the best in your exams.